Welcome to yet another episode of Three Plastic Surgeons and a Microphone. I'm Sam Jejurikar in Dallas, joined as always by Dr. Sam Rhee of Paramus, New Jersey, and Dr. Sal Pacella of La Jolla, California. Welcome, gentlemen. Before we get on to today's topic, which is going to be an exciting topic on cheek contouring and buccal fat pad removal by Dr. Sam Rhee, Dr. Sal Pacella is going to handle our usual legal business.
This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment. After appropriate discussion, always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something in this show. I think next time I do this disclaimer, I'm going to do it in some sort of Irish brogue or British accent or maybe an Italian accent. I don't know. What do you guys think?
I think those are
Italian accent be your accent.
Yeah, I was going to say it's not much of a stretch to do Italian. I think all of those are appropriate accents. You just got to be careful about which accent you choose.
Exactly.
All right. Well, Dr. Rhee, take it away.
We've talked a little bit about buccal fat excision in the past. It's extremely popular. The social media has really taken a hold of it recently and run with it. And in fact, our esteemed colleague, Dr. Rod Rory, commented on this a couple months ago. I'll just show a little video of him talking about it, as well as some of the findings that he had in his paper, which he recently published about it. So let me just pull that up.
But for our viewers that may not be familiar with the buccal fat pad, it is a piece of fat in the middle of the face, deep into the face, somewhere around the mid-cheek area. And it's been a technique popularized to help thin or slim out the face and augment the cheek lines.
Yeah, it's a procedure that has been around for a long time. Removal was popular 20 years ago. Was the Vogue done with many facelifts, went away for a while, and now is making a popular resurgence.
Yes, and in fact, it's going to be interesting because I'll show this, which was recently published a couple months ago, and you tell me what's changed about it at that point. So it'll be interesting. Is it bigger now?
Have you seen these plastic surgery posts on social media where baby fat from the cheek is popped out, literally through a small incision inside the mouth? Buccal fat pad removal went viral due to the striking yet subtle post-op changes, where patients emerge with slimmer lower faces and a more defined jawline. Despite the popularity, there's still a lot about the surgical's long-term efficacy we don't really know about. To learn more, the authors of this innovative hot topic performed an in-depth anatomic analysis of the effects of this procedure, short and long-term. Even though the surgery is relatively minor, involving a small incision inside the mouth, can be done under local anesthesia, and can take only under 30 minutes, it's certainly not without risk. The authors found that excessive traction or aggressive dissection can end up removing more than just the fat pad and could also affect the buccal branches of the facial nerve. This could lead to an excessively hollowed out appearance, premature aging, and nerve damage. They do state that if excision is controlled and limited to the buccal fat pad extension only, the short-term risks are minor. But still, there's no long-term evidence to show what happens to the face without the buccal fat pad over time. Remember, all facial fat compartments are important. This fat pad is very different. It goes from the superficial and the deep fat. Very important. So, the key to understanding facial fat is that the loss of facial fat in the face really predicates how you age. The more you lose, the more you age. That's why modern facial rejuvenation restores volume actually by targeting deflated fat compartments. The authors note that there is indeed evidence that buccal fat pad does diminish naturally as we age, but how much it does dissipate is still unknown. More evidence and long-term studies will be needed to determine if removing buccal fat to get that oval, beautiful heart-shaped face and defined jawline when you're younger, and does it truly not cause premature aging. But for now, the authors conclude that in the hands of a skilled plastic surgeon, this procedure can be performed safely. It is best reserved for those patients with naturally full round faces that have fullness in the front of their lower cheek above the jawline. Even if a procedure is trending on social media like Instagram, it might not be right for you. That's why we always encourage our patients to do their homework.
The more you know.
That's a great synopsis. I love how Dr. Rourke refers to the authors in the third person, even though he's the lead author on that paper.
He is one of the authors.
He is the lead author, and the rest of the authors were another one's one of my partners at present, and another one was a fellow who was with us. So I know all of these guys, and they're all great plastic surgeons. I think that's a great review, though. When Buccal Fat Pad removal was done a lot, in the 1990s, early 2000s, even the late 1980s, we were very much in the mindset in plastic surgery that removing fat was the key. Dr. Pacella is the eyelid expert amongst the three of us, but he certainly, I'm sure, was dealing with many patients who 20 or 30 years ago had lower eyelid surgery where their lower eyelids were totally hollowed out. We would take out fat from the lower eyelids. We would do facelifts, or we would do mastectomies, or take out large amounts of facial fat. And buccal fat pad removal went as well, and it gave people a very chiseled look, which looked awesome in the short term, but as they advanced 5, 7, 10 years down the road, it made them look prematurely older. And so it's interesting that this procedure has made a comeback. I will say that I've been doing more of it than I thought I would do, and I'll even have this conversation with patients, and I'll tell them, you're going to look older when we do this. And they all have a very quick retort, which is I'll get filler or facial fat put back in later on. I feel like patients sort of know that, but they very much in the short term are liking the chiseled look that they get from fat pad removal.
Yeah, and I think it's interesting because I rarely have patients come in specifically asking for this procedure. It's rare that someone will say, I want my buccal fat pad removed. I read about it or I saw it on social media. But it is part of a comprehensive kind of assessment of the face and tailoring your treatment. So, for example, in young patients, this technique can work very well if you have a full face around them and your jaw is a little widened. I usually use this in combination with not only direct excision through the mouth that can be done under local anesthesia, but I also give patients a bit of Botox, 2 or 3 injections of Botox into this area here called the masseter muscle. Many of these patients have hypertrophy of this muscle, which gives their face a much more boxy look. And so I think the combination of adding Botox there and doing the buccal fat pad can really make a huge difference.
Yeah, I think when I do these cases, they're in relatively younger patients. I usually do some sort of adjunctive technique like masseter or Botox injection, just like Sal said. And they usually get a very nice slimming effect. It's funny because Stuzen and Kawamoto wrote about this, and if you want, I'll show you the video that they did 30 years ago operatively about how to take this out, which was really exactly the same as it is now. And even then, Stuzen was pretty adamant about being pretty conservative about how much fat he took out. He said maybe 2-4 grams, something like that. Yeah. And everyone knows at that point what the risks were. And like Sam says, it's made a big comeback. I'm seeing more and more of these. I try to start with something relatively non-invasive, like the Botox to the masseter first. If they feel like they need to get some more slimming, I'll turn to the buccal fat pad in addition. Sometimes some neck lipo can be helpful too. And I'll show a case where we did that. But I'll just throw up an operative picture and then we'll see what that looks like.
As you're saying that, the only thing that I would say is different in my experience than Sal's is I have lots of people coming in asking specifically for this. They'll call it buccal fat pad. No one calls it the buccal fat pad. And they all think I'm pronouncing it wrong when I call it the buccal fat pad. But literally, probably every 6 weeks, I have a patient, a younger patient, early 20s, mid to late 20s deal, who specifically is requesting buccal fat pad removal. And so it's rare for me to actually make this something that I primarily bring up with someone, even though I do it every 6 or 8 weeks on someone. But it's driven by patients in my practice. And just like you guys, I'll do some Botox into the masseter. I commonly will do some submental and neck liposuction, usually using a radio frequency technique as well, just to really tighten the jawline, and all in combination, it gives them a much more chiseled look when they're done.
So let me show you a little bit of a diagram, and we can talk about the actual procedure here. So the buccal, or buccal in Texas, fat pad, is actually pretty large, and it actually extends all the way up over the temporal muscle. And what we really get is just the little bit of it that extends down into the mouth. And as Dr. Rourke said, it's pretty straightforward. It can be done under 30 minutes. You basically find the second maxillary molar, you make the Stenson's duct, and you just make a small incision. And the key to this is that even though it's a small procedure, there are structures in this area that have profound functional importance. And Stenson's duct is the opening where the parotid gland basically empties into the mouth. And if you were to lacerate it or misidentify it or somehow damage it, you're going to have a huge problem afterwards for something that you thought was a really small procedure. In addition, as Dr. Rourke mentioned, there are buccal branches of the facial nerve which are very close to the buccal fat pad. You can literally see, not here, but they are literally right there. And the facial nerve innervates the muscles of your face. So you can get a facial paralysis if this is improperly done. So what is relatively...
Sam, yeah, can I ask you, would you say that incision is accurate to where you make it?
No, I make it actually well away from Stenson's, probably about closer to the gingiva of the second maxillary molar. Probably.
And just in case our viewers are not clear, can you tell them what the parotid gland is and the parotid duct and what Stenson's duct actually is and what the problems are if you do damage that?
Right. So it's good. Thanks for reminding me. It's a salivary gland. So you actually have saliva that's produced in the parotid gland that is being tunneled or piped through this duct that goes from the gland that is right around your ear through the cheek into your mouth. And if you were to somehow damage it or block it, you would basically block the passage of saliva into your mouth. You could get a huge collection of saliva, which we've seen not in these cases, but in trauma, where we've all dealt with facial trauma before, where this duct was lacerated. And it's not a joke to have to reconstruct it. And did you guys ever encounter that in your travails in facial trauma?
Oh yeah, at Michigan, I had a gentleman who got into a bar fight with a glass and had a nice stellate laceration right over this area. It was about 4 a.m, and I figured out pretty quickly that he had lacerated Stenson's duct. And the interesting thing was, I placed a little piece of suture on the inside of his mouth through the duct on the inside of the mouth, and then it came straight out into the wound. So I knew immediately that the duct was violated. So. Interesting.
I saw a patient who had a buccal fat pad taken out elsewhere and had persistent swelling in the side of their face for 2 or 3 months and wasn't really getting anywhere with their primary surgeon, who was not a plastic surgeon. And so they ended up seeing me, and they had a persistent salivary collection inside their mouth. By that point, when you're that far out, it's impossible to reconstruct Stenson's duct. So drain was placed. They needed compression over that area. They needed what we call agents to basically try to suppress salivary production. It's a big to-do if that actually happens. Took from the time that they came in to the time that it was no longer a problem, took several weeks. I want to say almost 3 months to finally resolve. So it can be a huge problem.
That's absolutely
Now, Sam,
true.
getting back to that incision again.
Yeah.
So you make your incision in between Stenson's duct and the second molar, or right at that same level, but closer to the teeth?
I will usually make it a little bit closer. Well, it depends. Yeah, so I will make it a little bit closer to the... Well, this is not really that accurate, honestly. I feel like Stenson's duct is farther out a little bit, and there's more space between the mucosa of the second maxillary molar. There's more space there in which to make your incision.
Yeah.
And
Where do you
Samir, how
go,
about
Sal?
yourself? I usually go a little bit more posterior than what this shows, and kind of work my way back a little bit. So that's the approach I use for facial trauma, and I kind of know the exposure fairly well. So
I think they're trying to show it by the second maxillary molar, but the teeth are so crowded together in there, it doesn't look that posterior. But if you think about where it actually is in the second maxillary molar and how much harder it is to see relative in this picture, it's a little bit misleading. But yeah, what I'll do is I'll go... Again, I agree with Sam. The Stenson's duct is not so close to the incision, but I think that's just because of the way that the picture was drawn. I go right in the sulcus, make an incision, dissect using a pair of scissors so you see the buccinator muscle, tease through those fibers, and it should just pop out. So.
Yeah, it's a little. If you've never done it, I remember the first couple of times. Well, I did it all the time in my craniofacial fellowship because we would make cuts for our maxillary osteotomies, and you would always get into it, even though you didn't want to get into it, which was really annoying. But when the first time I intentionally did it, it was where I wanted to get to the buccal fat pad. You actually have to pop through the fascia a little bit, and it takes a little bit of doing to make sure you're a little bit confident to get through that buccinator and then get into that fat pad. So it does take a little bit of finesse to be able to know exactly where you are and to make sure that you're in there. And then once you're there, I tease out. I mean, how do you judge how much to take out? For me, it's more like I look at the patient, I see how much external fullness there is in the buccal fat pad. And I always take out just a little bit less than I think I really need in order to achieve the look that I think the patient wants.
I try to tease it out, let it fall out naturally, and whatever naturally extrudes, I take out. I try not to pull out and transect at the same time. Whatever naturally falls out when you pop through all that is what I'll take out. Less is more, I think.
Yeah, that's I do a similar technique, and it's very similar to what I would do for removing upper eyelid fat if somebody's really excessive. I just kind of gently press on the globe and just let gravity kind of dictate what comes out. Same sort of concept here, and I'm always kind of looking at the opposite side to just make sure I'm not creating an excessive indentation or anything like that.
Yeah. I mean, again, a lot of it is experience, and as you can tell listening to Sam and Sal, but when you do it, it's what you feel based on your feedback on the patient and your experience, what's appropriate. So that's really important.
One other point to make here is that certainly not for the faint of heart as a surgeon, but if you're doing a facelift and the newer techniques of deep extended facelifts, you're not far away from this plane to tease out the buccal fat pad, but you have to be exceptionally gentle. So many times if I'm planning a buccal fat pad removal and I'm doing a deep extended facelift, I'll lift up my tissue, go underneath the SMAS, take it extended deep into the face, make sure I'm not damaging any of the nerves, and you really just have to gently spread and you can get a good handle on this buccal fat pad externally. But again, not for the faint of heart.
I haven't done a deep plane facelift in like 25 years probably, and I don't plan on doing it anytime soon. You're right. It takes balls to be able to do that. That's all I can say.
Yeah, I also don't do deep plane facelifts.
So this is a patient who had a buccal fat pad excision. She also had a little bit of submental liposuction, and she actually came back. She came specifically for buccal fat pad excision and lipo. And then after this, we also did masseter muscle injections of Botox subsequent to that, which I don't have her most recent pictures on, but she was really happy with the results. She felt like she went from looking like a kid to basically like a young adult, which is what she is. And again, it just helps to contour and narrow the face a little, the jawline. It's not for everybody, as we discussed, but for certain patients, it's very powerful.
That looks great. Yeah, I think everything you did works in concert. You can see that she has a little bit of dimpling of the lower cheek area. That's the specific effect for our viewers of the buccal fat pad. It makes her look like she has more cheekbone definition. Then there's slimming of the jawline, which is a combination of the injections of Botox that you did. And then the side view really shows the effect of the neck liposuction, just how much more acute what we call the cervicomental angle is. And she just has a much more defined jawline. And even though I'm sure she's the same weight as she was beforehand, she looks much more chiseled. So really nice result.
Yeah. Great job.
All right, thanks. Any other thoughts about buccal fat pad excision or cheek contouring itself, or Dr. Rorik and his informational video?
Do either of you ever use the buccal fat pad as a donor for other facial fat?
I never have done that.
When I did craniofacial, we use it all the time as a pedicle graft for palatal fistulas for small defects, and it worked great, especially in younger patients who seem to have a lot of it, obviously, because it seems to be very bulky in children. I need to remember this technique more for facial fat grafting as well, because there are some patients I know that probably would actually benefit from repurposing it and redirecting it to malar or other areas. I just keep forgetting that's something that I should use. Do you use it a lot, Sal?
Not a ton. I think about it much more than I actually do it, just because majority of my facial aesthetic patients, I'm doing a larger volume of fat anyway that I'm harvesting from the abdomen, and just it's a little bit more precise. But I know people do excise it, chop it up, lay it down.
I think with the newer facial fat grafting techniques that are out there that I know you're using, it's just the quality of fat when you have it in a syringe and you're injecting it. Yeah, the Buccal Fat Pad would be kind of lumpy and irregular. Particularly if you think about the eyelid,
much more
which
malleable.
you do so much in, and if you're using fractionated fat, I'd be worried about using the Buccal Fat Pad in that scenario. And in terms of Sam's question, I think Dr. Warwick's synopsis is actually perfect. I think that it is very popular. It has a role in defining the jawline. It can definitely help with a chiseled look. For younger patients, know that there are long-term implications of doing this. So if you're okay continuing this whole facial rejuvenation process in your 40s, 50s, and 60s, like most of the people we see are in their 40s and 50s and 60s, know that you will have to reverse the effects of doing this procedure. But there's definitely benefits to doing it as part of a more comprehensive approach now. Yeah, I like that.
You'll look just like Sal.
Yeah, exactly. Exactly.
All right. Awesome, guys. Thank you so much. Have a great day, guys.
You guys do as well. Take care.